Okay, you're recording.
All right. Hello, students. I'm going to start off by extending my apologies. I forgot to begin recording at the beginning of the CCSE town hall meeting. Fortunately, before I got too far into it, I was reminded by a helpful student that this was something you guys really needed. So this is my makeup recording. I'm going to just go up to where we started recording in the main session. I think I can probably recapture everything we talked about pretty well, and I don't think there were many questions in the early part of the presentation. So I don't think you guys will have missed much. I'm going to do my very best to make it up to you with goofy word animation. So this is our COVID edition administration of the CCSE here in 2020, the weirdest year in human history. We are going to give the weirdest exam we've ever given. So we still have the same goals in giving the CCSE that we've always had. We want to know how effectively we're teaching you guys, how well our School of Medicine curriculum really works to give you the knowledge and skills that we expect you to have. We, of course, want to make sure that every one of our graduates has a minimum level of clinical skills competency that we feel comfortable signing off that you are ready to move on to the next stage of practice. Now, historically, we'd also wanted to prepare you for the Step 2 CS exam, but that's a little bit more of a question mark at this point in our lives because the USMLE has decided to indefinitely place the Step 2 CS exam on hold. Now, that decision was made actually after we made the decision to proceed with CCSE for this year. And we'll talk a little bit as we go through about the interaction of those two issues. But ultimately, even once we got this bulletin from the USMLE, we talked about it and decided to proceed with CS because there is no guarantee that the USMLE isn't going to pick back up with the same old CS exam at any time. They could announce in October, okay, you know what, we've decided we like this exam, we're going to keep doing it, and that's going to, you guys could end up being required to take it. So we wanted to make sure that you have some preparation, even though there is the potential for this exam to go away altogether or to change significantly in the months and years ahead. All right, so what's new for 2020 in our COVID edition CCSE? Well, first, we're going to be doing online exam administration. As you guys may have noticed in human society, we are no longer physically interacting with one another in a face-to-face setting, or we're doing that in at least much more limited ways. So the CCSE is going to be no exception. We are going to conduct the exam online using video conferencing via Zoom, which you are all probably painfully familiar with at this point. We are going to be not just using regular old Zoom, though. We're going to be using a technology platform called SimIQ, which is going to actually be our new clinical skills assessment system for the entire simulation center. And it can be used for traditional in-person standardized patient exams like you've taken before, but it can also be used in a way that's integrated with video conferencing via Zoom to bring together the recordings from the standardized patient encounters along with the checklist for the SPs to fill out and the post-encounter notes for you to fill out. So all of those get integrated together into one package. They get stored securely, and that allows us to obtain the necessary data to score and analyze the exam. So from your perspective, this is going to be pretty straightforward. You guys are all probably watching this on Zoom right now. So you clearly have the ability to do that, but you are going to need a laptop or a computer. We don't want you doing this on a mobile device. You're going to need high-speed internet. You're going to need audio video capability. So you're going to need to be able to see the SP, and they're going to need to be able to see you. And of course, both parties will need to hear each other as well. Most importantly, you're probably going to need a little bit of patience and understanding because we have never done an exam of this length or complexity on any online platform before now. And this is actually going to be our first major trial of SimIQ, which the Sim Center only acquired a couple of months ago. So we've done lots and lots of testing. I promise we're not just throwing you in as guinea pigs, but this is going to be our first major academic endeavor using this platform. And while tons of groundwork has gone into this to make things go smoothly, I can guarantee there's going to be glitches along the way. And I'm just going to thank you up front for your patience in that regard. So, what does the CCSE look like? Well, it is still going to consist of 12 stations. And just as a little historical note about that, the CCSE has always, well, not always, but for many, many years now, consisted of 12 stations. It's a large enough number of stations to give us a pretty reliable, stable set of scores. There's much more variability and issues with reliability and validity when you use a smaller number of cases. So 12 has always been a good number for us to have an exam that performs well. We did consider for this special magical COVID year doing a shorter exam, and your student leaders actually came to us and said, no, we like the variety of cases that you provide in the 12-station exam, and we think it is valuable to have a full day exam experience which simulates what's going to happen on Step 2 CS. Now, again, we know that Step 2 CS may look very different in the future. It may not even exist in the future, but students felt like there was significant value in keeping the longer exam format to give you experience with the widest possible variety of cases, as well as the physical and mental stamina that's necessary to complete an exam like this. So if you don't like the longer format, don't be mad at me. Talk to your student leaders. Okay. The good news is that within the 12 cases that we're going to be providing you, they're all standardized patient encounters, and there's nothing weird about them. There's no zebra diagnoses. We're not going to be making you figure out Wegener's granulomatosis or histiocytosis X. You're not going to be parsing some kind of elaborate family pedigree to figure out the inheritance pattern of some arcane disease. You're going to be looking at common complaints that normal people come to healthcare with. This hurts. That hurts. I'm coughing. I'm short of breath. My stomach hurts. I have a fever. I have a headache. These kinds of things that we see in healthcare every day. Now, I know that y'all have been back in the clinical area since COVID started, so you might not actually have seen a lot of people coughing or with respiratory complaints since we're working so hard to keep you away from COVID patients. But for the most part, these are all going to be bread and butter medical complaints that you're going to be comfortable with. There is some variability in the difficulty of the cases, though. So some cases are going to be pretty straightforward, slam dunk, one or two things in your differential, not a lot of complexity. Other cases are going to be more nuanced and are going to allow for a broader differential diagnosis and are going to require you to probably dig a little bit deeper and get a little bit more detailed information to decide what's wrong with the patient. So that's intentional. Some cases are easier, some cases are harder, but none of them are arcane. None of them are things that you won't have experienced in your own clinical practice to date. I also want to reassure you that all of the cases that we're using were either written by Hopkins subject matter experts or at least edited, adapted, and reviewed by the people who are teaching you every day. So we all agree that this is content that you can and should have mastered. All right, so what do the cases look like? You're going to have a majority of cases that would fall generally into the internal medicine domain, which is not that surprising. There are a couple of pediatrics cases, a couple of general surgical cases, a couple of OBGYN cases, one or two neurology and psychiatry cases. Now, for me in emergency medicine, I consider all of this to be my domain because we see patients with pathology from all of these specialties. So we do have several cases that take place in the emergency department. And actually, every single one of these cases are things that I could and have seen in the emergency department setting. That said, they're not all intended to be high acuity cases. A lot of the patients you'll be encountering in the clinic setting. Again, several of them in the emergency department. One of them will be a telemedicine encounter, and that is a pediatrics case. Now, one thing I want to emphasize about this, technically everything we're doing in this exam is telemedicine, right? Because we're not physically with the patient, we're talking on the computer. But we are pretending, simulating a real life encounter. We are not setting this up like a telemedicine encounter with all of the inherent limitations of telemedicine. We are setting this up as an encounter where you are really in the room with the patient, where you are able to examine them, where you are able to obtain tests and perform treatments, etc. So we want you to suspend your disbelief and imagine that these are cases that are taking place in real life. The one other thing I'll mention about our settings is you'll note that there's no inpatient cases. So none of these are going to be like super high acuity hospitalized patients. You're not going to be like called stat to the ICU for somebody decompensating. It's not like that. These are all cases that are amenable to outpatient evaluation. Okay. So you guys all, I think, know a fair amount about standardized patients. We have amazing standardized patients at Hopkins. They're great at reliably simulating every aspect of patients, from their history to their physical exam to their personality and communication style. Their job, in addition to portraying the patient during the encounter, is also to assess your performance. So they report on what happened during the encounter. Did you or did you not ask a particular question? Did you or did you not request, not perform, because we're not going to be together, but did you or did you not request a particular exam maneuver? And we'll talk about that in a second. How effectively did you communicate with them? Those are the kinds of questions they're going to be asking. It's important for you to understand they are not in a position to judge whether you have the right answer, whether your diagnostic reasoning is valid, whether you've made the right decisions. They are not medical people for the most part. So they're not going to be reporting on those aspects of your performance. Those things are going to come out in the patient note, whereas the standardized patients on the checklists and rating scales that they do are just going to be reporting on what they observed during the actual encounter. So history taking is going to look just like history taking will look in real life. You're going to interact with the patient exactly the same way you would in person. And I strongly, strongly, strongly encourage you to do that in an orderly, systematic way. Just like you wouldn't hop all over the place and ask all kinds of crazy questions in real life, you don't want to do that in telemedicine. Ask about the history of present illness, then the past medical history, the meds, the allergies, the social, the family. Go through it in the order that you've learned, and you're not going to miss anything. And this is important because all of these cases have clues embedded in different parts of the history to help you get the right answer, to help you come up with the right things in your differential. So if you miss any of these elements, you're going to be robbing yourself of valuable information that you could use to figure out what's actually wrong with the patient. And guess what? That's not just true in these cases, although in these cases it's very intentional. That's also true in real life. When we miss pieces of our history, we miss opportunities to understand what is wrong with the patient. Physical exam. Now, clearly, we're not going to be flying out through the computer screen and looking in people's throats like we're seeing in this illustration. We're going to not be able to do much in the way of physical examination during these encounters. That said, there are some physical exam maneuvers you can do via Zoom. You could do at least limited neurologic exam on me with me sitting right here at the computer right now. So if there are maneuvers that you can perform, if there are things sort of above the waist that you would like to observe, you can ask the patient, hey, stick your tongue out for me, or whatever it is that you want to do. And they will either do what you ask, or they will report the result of that maneuver to you. We've told them that they're permitted to do whatever is more comfortable or natural for them. Most of the maneuvers that you're going to want to do, though, you can't physically do via Zoom. So in particular, you obviously can't use examination instruments. You can't shine lights at people over Zoom. You can't use stethoscopes over Zoom. You can't use reflex hammers over Zoom. So you're not going to be able to do any of those things. We're also not going to ask that the SPs do any elaborate machinations to show you parts of their bodies that would require readjusting the camera angle or standing on a chair or whatever. So they're only going to demonstrate things that they can demonstrate sitting comfortably at the computer. You're not going to be able to look at feet or legs or anything like that because that can be too challenging for their setups. So basically what you're going to do for any exam maneuver that you can't do via Zoom, you're just going to say, I would like to do X. And then they will verbally report that result to you. Now, why are we doing it this way? Well, very simply, we can't on Zoom assess your ability to correctly perform a physical exam. It's unfortunate, but we simply can't do that. What we can do is assess your knowledge of the appropriate exam maneuvers to select in a particular clinical scenario. So based on the history of the patient, based on your differential diagnosis, there are particular maneuvers that you should be doing. There are things you should be checking for, and we can measure your knowledge of whether or not you're doing those things. So we're missing the psychomotor skill part of the exam, but we're still getting the cognitive part of the exam, which is knowing what pieces of the exam to do in a given situation, which honestly for me as your primary examiner is more relevant. I care more, do you know what to check for than do you know how to check it? I feel like you've had 4 years to learn how to correctly perform a physical exam, and I'm okay believing that you know how to do that, but I do often see students and early residents come present patients to me not having done exam maneuvers that I consider to be critical. So I'm more concerned about your ability to choose the right maneuvers to do. So how are we going to do this? For very basic stuff, it's very simple. Ask and ye shall receive. So basic, normal, standard exam maneuvers just say, I would like to listen to the lungs. And the standardized patient will say, my lungs are clear. Or they'll say whatever their finding is in the lungs. However, there are complex maneuvers that might require a bit more explanation. So very basic stuff, just ask and they'll tell you. And the things that come up again and again and again are pulmonary auscultation, cardiac auscultation, and abdominal palpation. So if you simply say, I'd like to listen to your lungs, I'd like to check your breathing with a stethoscope, some kind of phrase along those lines, the SP will know what you're trying to do. They're not going to demand that you explain where you're putting the diaphragm or the bell and what rib level and blah, blah, blah. They're just going to tell you my lungs are clear and get on with it. However, there are some exam maneuvers that are a bit more specialized, and they might ask you just to make sure you have an understanding of how to perform the maneuver and that you are asking for the maneuver that you think you're asking for. So if you want to know about a Robsing sign for appendicitis, if you're worried about an MCL tear on somebody with a knee injury, you can't just be like, what is the anterior drawer test? They're going to want you to explain what that looks like. If you want to do a neurologic exam, you can't just ask, is there dysdiadokinesia? They're going to want you to explain what is the rapid alternating movements test and how would you like them to perform it. So bottom line is for any of these sort of higher complexity exam maneuvers, the SP is going to be trained to say, sure, that's fine. Tell me what you'd like to do. And all you need to do is explain to them either what you want them to do or what it is you're going to do with them. So just explain it in simple terms, just like you would with a real life patient. You know, I'm going to press on the right-hand side of your abdomen, and I want you to tell me if you feel it. I'm sorry, I'm doing things backwards because I'm tired. I'm going to press on the left lower side of your abdomen, and I want you to tell me if you feel it on the right. You know, so just tell them what you want, and they will get it. Okay. There are some gray areas here. So there might be times when you think you're asking for something simple or clear and you're not. So for example, you might say, I would like to check the strength in your face. And they're going to be like, okay, what does that mean? What do you want me to do? You want me to close my eyes? You want me to show my teeth? You want me to turn my head? Like, what is it that you want me to do? So just explain. I want to check the circulation in your feet. Well, that could be temperature, that could be color, that could be capillary refill, that could be pulses. So they're going to ask you, what do you mean? What are you actually checking? So again, they're not trying to trip you up. They're not trying to mess with you. They just want clarity on what maneuver it is that you're asking for so they can give you the right data and so they can give you credit for performing the right maneuver. So just describe it in simple terms, just like you would with a patient, and you'll be fine. All right, I think this is where a thoughtful student asked me, Dr. Young, is there going to be a recording of this? And I realized that I hadn't been recording, and I started recording. So you're going to hear about intimate exams and all the rest coming up in the second part of the video. So thank you guys very much for your attention. Don't hesitate to reach out to me if you have any questions about the exam, and I wish you the very best of luck. Bye-bye.